Good afternoon all. I am Dr. Karunakar, working as consultant critical care at Apollo Institute, Hyderabad. I thank ISCCM Hyderabad chapter for giving me this opportunity. Today my topic is brain death in ICU. So first we'll move on to typical case scenario. So a 34 years old man was brought to the ER following a witnessed cardiac arrest in the street. A bystander had immediately started CPR and called for help. Then paramedics arrived and ROC was achieved after a few minutes. The patient was shifted to ICU for further management. In the ICU, he was brought to unconscious. GCS was even VTM3. Pupils were equal and reactive. His heart rate was 98 beat per minute and BP was 90/60 with a minimal heart support. He was being ventilated. After 5 days, there has been no significant improvement in patient condition. His GCS has worsened and remained at even VTM1 even after stopping sedation for more than 2 days. His other lab parameters are normal. Family asking about the condition of the patient, prognosis, whether my patient is alive or dead. So there is a need for defined brain death. So the need for defined brain death. Definition of brain death is required to retrieve organ or tissues from person's body. This to discuss with the attendants regarding the patient on artificial life support mission no longer had any brain functions. So, and the idea of the brain death by neurological criteria was first recognized in 1959. They defined as coma deposit. It means a state beyond coma. Subsequently, the Harvard Brain School defined as irreversible coma. It consists of totally unresponsiveness and no cranial reflexes, no respiratory efforts. So, in 1995, American Academy of Neurology defined as irreversible coma with a known cause, absence of brainstem reflexes, and irreversible apnea. The diagnosis of brain death is clinical in nature and supplementary tests to be used in the presence of confounding factors. They emphasize that whole brain death to be followed instead of brainstem death. Whereas in UK in 2008, Academy of Medical Royal College emphasized that in contrast to whole brain death, the diagnosis of brainstem death is sufficient. So that we have to do brainstem reflexes and apnea tests. As we follow UK guidelines, we also do a brainstem testing and apnea testing to be confirm brain death. So as we discussed types of brain death, since then many other guidelines protocols have been published, adapted, revised throughout the world with the general acceptance. The new concept arrived in recent past in 2020. It was published in JAMA. It says the brain death or death by neurological criteria is defined as complete and permanent loss of brain function as defined by an unresponsiveness coma with loss of capacity for consciousness, brainstem reflexes, and the ability to breathe independently. So finally, higher brain death. It is proposed by Viaj and others. It is based on another definition of death. It means irreversible loss of personhood. So diagnosis of brain death in India. The diagnosis of brain death in India is medically and legally defined as total and irreversible cessation of all brainstem functions. Brain death stem is required to discontinue artificial ventilation and to ask legal consent for organ donation from relatives. We have two laws. So Transplantation of Human Organ Act in 1994 and 1995. They conclude who should diagnose. The team of 4 medical experts can diagnose. These are other authorized specialists, authorized neurologist, neurosurgeon, medical administrator in charge of the hospital, medical officer treating the patient. So there are some conditions: unrecognized intoxication, Lockley syndrome, high C-spine injury, hypothermia, and fulminant Guillain-Barré syndrome may mimic brain death. So Another condition that profound anoxic brain injury with a marked cerebral edema. These patients can have respiration or attempting apnea test, but patient has no cranial nerve or responsiveness to pain. These condition will give false positives. And then we'll move on to guidelines. So to determine brain death, these are the practical guidelines. There should be coma with a known cause and the absence of brainstem reflexes. Apnea test should be positive. These evaluation is not confined, you have to do ancillary test and followed by you need to document. There are some prerequisites and confounders to count for brain death. There should be established irreversible and proximate cause of coma, and should be exclude the conditions like CNS different drug effect, alcohol intoxication, neuromuscular blocking agent, serum electrolyte abnormality, acid-base neuroendocrine system. If present, they should be corrected. The normal temperature, core temperature should be 36 degrees Celsius, and adult must have systolic blood pressure at least 100 millimeter of mercury, and MAP should be 60 millimeter of mercury. Drugs can be interfered. So it should be excluded by serial measuring drug levels, allowing 5 elimination half-life to pass, and performing on ancillary testing in addition to the complete clinical examination and apnea test if there is concern about prolonged or unknown drug elimination. So after completing this confounders and prerequisites, we move on to clinical evaluation. So clinical evaluation mainly we test brainstem. The brainstem includes midbrain, pons, medulla. So for clinical evaluation, first of all, you need to confirm coma. There is no evidence of arousal or awareness to maximal external stimulation. So then move on to pupillar reflex. For pupillar reflex, you have to test cranial 3. If cranial is not intact, you will not see pupillary constriction. Pupils will be like fixed directly in a brain. But constricted people seen in drug intoxication, locked-in syndrome, quantum bleed, corneal trauma, or any ocular installation like atropine, these may cause sight difference. In the case of anophthalmology, ancillary test is necessary. For corneal reflex, you need to test granulars 4, 5, 6. When you touch the cornea with a cotton swab, the corneal nerves intact, corneal reflex will be there. So if no corneal reflex, it's confined brain death, but care should be taken not to damage cornea. In case of anophthalmia, severe optic edema, you need to consider ancillary test instead of doing corneal reflex. Then next, we'll move on to oculocephalic and oculovestibular reflex, otherwise for dorsal. These will test cranial 3, 6, and 8. When you rotate the head briskly horizontal to both sides, there should be no movement of eyes related to head movement. That means there should be absence of extraocular movement. But before doing the dorsal test, you need to check cervical spine, should be integrate of the cervical spine before doing test. If the oculocephalic reflex cannot be performed, you can do OVR oculovestibular reflex. If there are no extraocular movements, ancillary testing is not required. There are some conditions you have to consider ancillary testing like anophthalmia, severe orbital and scleral edema, a fracture of the base of the skull or petrous temporal bone. So oculovestibular reflex, when you irrigate the ear with the ice water for at least 60 seconds by using syringe, you have to test both eyes separately with a 5-minute interval. There should be absence of extraocular movement. When the cranial 3, 6, and 8 not intact, you may not see the eyeball extraocular movement. So before that, you need to integrate, you need to ensure the integrity of tympanic membrane. In the presence of ruptured tympanic membrane does not negate the clinical testing, but may risk introducing infections in the ear. Well, move on to cough and gag reflex. Cough and gag reflex will do like stimulate the posterior pharyngeal wall bilaterally with the tongue depressor. For cough reflex, it stimulates the tracheobronchial wall to the level of the carina with a deep endotracheal placement of suction catheter. As the medulla is not intact, the cough and gag reflexes will disappear. So there is some condition, high cervical cord injury. You may in that condition, pharynx may damage, so it will give false positive. So in this condition, ancillary testing is recommended. So we'll move on to motor response. Motor response with face and lips. When you apply deep pressure to the temporomandibular joint, nail bed, supraabdominal compression, you will see the grimacing reflex facial movement. If the nerves are intact, cranial intact, you may not see facial muscle movement, motor response. But while doing motor response testing, there could be complex spinal reflexes, muscle fasciculations, ventilator artery. These should be discussed with experts and should be ruled out. In these conditions, answer testing should be undertaken. Also consider ancillary testing in severe neuromuscular disorders. Then we'll discuss on who will certify brain death. According to amendment in the TOVA Act 2011, in the event of non-availability of the approved neurosurgeon, neurologist, the surgeon, physician, anesthetist, or intensivist can certify brain death. After completion of clinical examination, neurological examination, apnea testing is important. What is the implication of apnea testing? Apnea testing is done to create a degree of hypercarbia to stimulate the respiratory center. Apnea still persisting after apnea test, it denotes brain death. Apnea testing consists initially we should establish the cause for the irreversible brain damage. Secondly, we have to do brainstem reflexes. They should be absent. Then comes the apnea testing to confirm the brain death. There are some prerequisites for doing apnea test. It should be like at least 24 hours. Should be wait from CPR. Patient should be normothermic, normotensive, eucapnic. Better have active line in place for sampling. There should be absence of pulmonary disease. So to determine the brain death, the neurological criteria, who is a person with a therapeutic hypothermia. When a clinical examination suggests of brain death in person with hypothermia with a potential cause to irreversible brain injury, we should rebound and obtain neuroimaging. If neuroimaging is positive, you have to wait 24 hours after rewarming, and you need to wait till temperature is 36 degrees Celsius. After that, if you assess recent administration of any CNS replacement medication, you need to wait till delay the determination of brain death by doing serum drug levels. You have to wait till 5 minutes of off life. Then you need to perform clinical examination and apnea test. Apnea testing, before doing apnea testing, you need to adjust ventilator settings to achieve eucapnia. The patient should be pre-oxygenated with 100% oxygen for at least 10 minutes to achieve PO2 more than at least 200 millimeter of mercury. Artificial is beneficial for continued blood pressure monitoring. The ratio of internal cannula diameter to the internal interstitial tube should be less than 0.6 to 0.7 to avoid epidemic inflammation and barotrauma. The oxygen flow rate at like 4 to 6 liters minute in adults. In that, CPAP also can be used with the risk. We were in risk of cardiopulmonary instability. So, viewer require high peak can be done with the CPAP. Apnea test targets are pH should be less than 7.3 and PSCO2 should be 60 millimeter of mercury. Documentation of apnea test. After pre-oxygenation with 100% oxygen, you have to take KBC and disconnect patient from mechanical ventilation. Then continue oxygenate through the catheter placed in the trachea to maintain saturation above 95%. ABC to be repeated within like 8 to 10 minutes. If increase in PaCO2 above 60 or 20 millimeter of 20 mm increase from baseline is consistent with apnea. A repeat apnea test to be done 6 hours after first apnea test. So when to abort apnea test? So when you're doing the apnea test, if you see any spontaneous respirations, patient having hypotension even after optimizing vasopressors, patient desaturation, you have to abort the apnea test, connect back to ventilator. To overcome this, the modified apnea test is advocated. So modified apnea test can be done with the peak wall and CPAP. By using peak wall, you can deliver 100% oxygen after disconnection from ventilator. It does not interfere with the hypercarbon. The CPAP with the apnea test. So this especially in a patient with high dose of vasoconstrictor, you can use you can do apnea test with the CPAP. It will prevent decrement of the lung, reduce the risk of hypoxemia. All patients had PaCO2 elevation of more than 60 mmHg at the end of 10 minutes, but the decrease of hypoxemia is less in with the CPAP one. Apnea testing can be done in ECMO patient. So you can see in the diagram, the extracorporeal blood flow is modified. Will not modify. Extracorporeal gas flow will reduce to 1 liter per minute. The extracorporeal FiO2 will be increased 100%. After disconnecting the ventilator, you have to connect ambibag with PEEP wall. You have to continue till 80 minutes apnea test. If you encounter any desaturation or hypoxemia, you need to connect to ventilator. After the apnea test, ventilator and extracorporeal settings are returned to baseline values. Then, after completion of clinical exam of brain reflexes, apnea test, these are the supplementary test only, not a diagnostic test. Ancillary test can be considered. Cancer test can be done in facial trauma, pupillary abnormality, severe pulmonary disease, tox level of sedative drugs, sleep apnea. CT angiography. You can see in the absent filling at the point where the internal carotid artery and vertebral artery enter the skull base. Nuclear or PET state survey. There is an absence of uptake isotope in brain parenchyma. That is called hollow skull phenomenon. TRANSCRANIAL Doppler can be done at the bedside. It's a non-invasive bedside test. You can see the small systolic peak in early systole and diastolic reverberant flow. Then after that, EEG can do, but no longer be used. But it may be required if mandated by regional laws and the policies, or cardiovascular impedance. Somatosensory evocative potential. In this, the brain death confirmed by bilateral absence of N20 P20 response with the median nerve stimulation. After that, you need to document brain death by neurological criteria. The documentation including etiology of the coma, absence of confounders, full details of clinical testing performed and results, neuroimaging results, reason for type of NC testing, time of death. If you suggest the time of death, we noted in accordance with reason resignation. If two examiners are required to declare death, the time of death be the time as the second exam is completed. Thank you.